Good afternoon, everybody. So I am really excited to spend some time with all of you talking about the COVID-19 pandemic. And what I'm going to do is I'm going to speak for about 20 minutes. And I want to keep the remarks just to about 20 minutes because I want to make sure we have plenty of time for Q&A. And in those 20 minutes, what I'm going to try to do is start global, talk about where we are in the pandemic, move to a national exam of kind of where we are in the country, then talk about Massachusetts. And then there's lots of other questions out there about therapies and vaccines and what the healthcare system will look like, some of which I will cover and touch on, but I'm hoping that we can really delve deep into all of those issues in the Q&A. So lots of time for Q&A. So let's get started with the big picture. Where are we in this pandemic? I think of this as an 18-month pandemic. And if we are lucky, that's what it will be. And if we mark the beginning of it as January 1, though it began in China before then, but if we say January 1 of this year, my hope is that we will have a vaccine that's safe and effective and widely available by July 1 of 2021. That gives us an 18-month time period to get through. If we stay with that and we use a baseball analogy, we are in the bottom of the third inning. This is a baseball game that all of us are hoping does not go into extra innings and that it will really come to a close or at least to a major turning point by next June or July. That's the hope. So if we're in the bottom of the third inning, how's it going so far? How's the game going so far? Well, what this pandemic, we've got about 7.5 million people who've been identified as having been infected, about 400,000 people dead. That's across the world. The U.S. represents about a quarter of that in terms of both number of cases and deaths. As you all know, about 2 million people have been infected in this country or identified as infected, and about 110,000 Americans have died. We are still very early on, and so it is very tempting as we come out of lockdown and look at the summer, very tempting to think that the worst is behind us. I would like to remind us that we have a long way to go. Just thinking about the global picture before I delve into where we are in the US. This is a pandemic that began in China, shifted to East Asia, Singapore, Taiwan, Hong Kong, South Korea, Vietnam as the countries that sort of were next hit, moved to Western Europe. We saw that in Italy, Spain, France, Germany, UK, then came to the United States in terms of where the kind of epicenter was. And what I would argue is that we are, while we remain the country generating the most number of new cases every day, about 20 to 25,000, the epicenter of the disease is really shifting away from us. And that's a good thing, by the way. And I wish it would shift even more away as if we could bring our caseloads down. But while we will continue to be a major source of the infections and continue to have a lot of cases in the United States, I am deeply worried about in the upcoming days and weeks ahead. We're going to see a lot of cases across all of Latin America. Brazil is really the epicenter, but Peru and Chile and Mexico are being hit very, very hard. There are parts of Eastern Europe, Russia really the big one, where we're seeing a lot of cases. And then India has been in this massive lockdown for 2 months. They're coming out of that lockdown, and we're seeing a big acceleration. The reason it's worth bringing up these other countries, first of all, it's important. We live in a global world, and it's worth understanding what's happening outside of our borders. But second is that the more that there are disease outbreaks happening in other parts of the world, they become seeds of infection into our country. And right now, just to be very frank, much of the world is seeing us as the seeds of infection into their countries. So countries are opening up, New Zealand, Greece, Iceland, and they're actually not letting Americans in because there's so much infection in this country. So we are actually on the receiving end of a lot of travel bans. But just worth remembering that we're in a truly global world. Let's talk about the United States. So in the United States, where we are right now, as I said, about 2 million cases identified and about 110,000 deaths. The center of this outbreak in the US in the last couple of months was really the greater New York area, New York, New Jersey, Connecticut. Those were the places that saw the large number of cases. What has happened over the last month, I'd say over the last 3-4 weeks, is that the nation has really plateaued. We went up, we spiked, we flattened, and we've been slowly drifting down. But that slow drift down, if you look at the country, you can convince yourself that we're at about a standstill in terms of new cases every day, not going up, not going down. But it actually misses a much more important point, which is that the epicenter of the disease, New York, New Jersey, Connecticut, they are seeing, and Massachusetts, actually, I would put in that list, are really seeing dramatic declines in cases. So if the epicenters are seeing dramatic declines, but the country is flat, that means there must be other places that are seeing dramatic increases. And indeed, that's true. So we're seeing large increases in the number of cases in Arizona, in parts of California, North and South Carolina, Florida, parts of Texas. So places that were not so hard hit initially are starting to really get into trouble. And what I expect over the next few months in the United States is more or less more of this, that we will have states that will get into trouble. They may put in some restrictions, try to ramp up some testing issues. But fundamentally, the disease is going to continue to spread. It's going to start in big cities, as it always does, move into the suburbs, and eventually into the rural areas. And the health and the healthcare implications of all of that are nuanced, and many of you can imagine what they are. So if you just think about the fact that diseases are going to move from cities to rural areas, cities, disease transmits faster, a lot more density. As you get into the rural areas of America, you're going to have people who are older, living in areas with far less hospital capacity, far less ICU capacity. And so there will be really important questions about how do we take care of older people living in rural areas that are getting infected with this disease. We've already started seeing it in places, but I think over the weeks and months ahead, we're going to see a lot more of that. And that is going to be an important issue that we're going to be confronting. Okay, so moving on to talking about where we are in Massachusetts. So as you know, all of you know, Massachusetts, we've seen a very nice steady decline in the number of cases over the last month or 6 weeks. And that's been great. And it's one of the few states in the country that has been able to kind of achieve that very steady decline day by day. We have seen just in the last few days a little bit of a bump up, and I'm still trying to sort out why that is. But we've had about an average of about 900 to 1,000 new positive tests a day. If you look at the underlying modeling data, the modeling data suggests that we're probably generating about 3,000 new cases a day. And I can explain maybe in the Q&A how one gets at that from the modeling data. But what that means is that we're only getting about a third, or we're missing about 2/3 of the cases that are occurring in Massachusetts every day. So we think that while Massachusetts has generally done better and it continues to see a decline in cases, there are still substantial challenges. Obviously, we've made a lot of progress in Massachusetts on testing. And where we are right now is that we're at about 9,000 or 10,000, about 9,000 tests per day. There are varying estimates of how many tests we should be doing as a state. For the size of the outbreak we have, what's really clear to me is that we should be doing a lot more tests than we are. And so while we're one of the best in the country in terms of testing per capita, and you might have seen a Boston Globe editorial from yesterday or maybe Sunday that really called on the governor and the state to substantially ramp up testing, not because we're lagging behind other states, but because we have a pretty large outbreak compared to a lot of other states. We still have a lot of cases, new cases. And second, if there's any state in the country that is poised to be able to really deliver on ubiquitous testing combined with tracing and isolation as a strategy for suppressing the virus, it is Massachusetts. We have not to be overly humble about it, not that I had anything to do with it, but we have the best life sciences industry in the world. And so if there's one state that can really pull off, many tens of thousands of tests per day, it should be Massachusetts. And I guess I would say I'm optimistic that we can get there, but we're going to need to continue to put pressure on our political leaders and our healthcare leaders to achieve that. Okay, so let me make a couple more quick remarks, and then maybe I'll stop and take questions. So one of the questions that does come up is, why do we need so much testing? What's the purpose of all this testing? And the big picture point I want to make about testing, and why I think Massachusetts needs a lot more testing than we have, is remember, the whole purpose of testing is to identify people who are infected so you can separate them from people who are susceptible, so you can slow down the disease spread, right? That's the entire purpose. And if that's the goal, which it is, then we need a multi-pronged strategy on testing in Massachusetts, as we do, I think, across the country. We certainly need to be able to test anybody who's had even the mildest of symptoms. There has been some confusion, if you've been watching the news in the last 24 hours, about whether asymptomatic people can spread the disease, right, based on some comments WHO made. So let me just clarify. The short answer is yes. Asymptomatic people can spread the disease. They do spread the disease. We think that as much as half of all cases are from people who were asymptomatic spreading it to somebody. So it's a major source of spread. So given that, it's really hard to identify all the cases that are out there. So as I said, I think right now in Massachusetts, we're missing at least 2/3 of all the cases that are occurring every day. So how do we get better? How do we capture more of those? Well, we have to test more, but it's not just about having more tests, it's about being smart on testing. So we need a very aggressive testing strategy in hospitals, in nursing homes, in factories, in workplaces. If we go to opening schools in the fall, I am very worried about this issue. I think that schools can open in the fall. I think they should open in the fall. And yet what I see across not just the Commonwealth, but across the country, I am deeply worried that most schools will not be actually able to open in the fall. So there's a large gap between what we can do and what we are likely to end up doing. And having the entire school system shut down, not just in the fall, I always say to people, well, you're going to close in the fall. What's magically going to get better in January or February or March? So are you really saying you're going to be closed until April or May? And I think that's where we're heading, unless schools get very, very aggressive and very, very smart about how they're going to open up. And a part of that strategy, certainly not the whole thing, but a part of that strategy is going to have to be the availability of ubiquitous testing. Right now, with 9,000 tests a day, or even up to 25 or 30 or 35,000 tests, that probably is not going to be enough for the Commonwealth by the time we get to September, October, and have to keep our schools and colleges open. And given how important that is to our economy, I think it's going to be really central. So I really think one of the places Massachusetts has to push harder is on testing. One of the questions I've gotten asked a lot is, what do I think about phase 2 opening? And we are opening up. It's clear. I mean, if you're out and about at all, you can feel that things have really changed just in the last 2-3 weeks. I expect that that's going to lead to more cases. Will it lead to large spikes? Hopefully not, probably not. One of the things that we're learning, and this is much more preliminary, is that we think that transmission is much lower when you're outside. We think transmission is lower when it's warmer and more humid. And so the seasonality issues of the summer may really be helpful to us in reducing the amount of spread there is. Nothing definitive. I don't think it'll make the disease disappear, as our president had speculated that it might. I think we're going to continue seeing a good number of cases all throughout the summer, but I think we will likely avoid the large spikes up with the disease, partly because it's summer and people are outside and it's warmer. Worth thinking about the fact that seasonality is a double-edged sword. The benefit of seasonality, which is the summer won't be so bad, is the detriment of seasonality, which is when it comes to October and we can't keep our windows and doors open and we're not spending as much time outdoors, it'll get harder and harder to slow down and stop a big spike. And that's why I'm very worried that between October and March, we're going to have a very hard time. The only last point on that is that it's going to coincide with the flu season. And so our hospitals are already going to be overstretched. And so we really need a very detailed and aggressive strategy to make sure that our healthcare system is ready for the fall and winter and is poised to be able to manage what is likely to be. Now, we might get lucky, right, and then have a mild flu season. That would be great, or a really effective vaccine. But I think we should plan for what is likely to be potentially a serious flu season along with a bad COVID season. So that's what's ahead of us. Let me just finish up by making this one last point. There's a lot of other issues I haven't covered: the healthcare system, loss of elective surgeries, how we prepare for the fall, therapies and vaccines, all of which I'm happy to get into. But I will say this, which is, as I look out to the upcoming weeks and months and really over the next year, I see one of two futures. Future number one is the path we are on, right, which is 800 to 1,000 deaths a day, 25 to 30,000 deaths a month, getting to 200,000 deaths by September. And that's almost like surely where we're going to end up. And then after September, picking up. And so when people have asked, and most experts estimate, and when I'm honest with myself and ask the question, if we more or less keep doing what we're doing, where are we going to be by next April, May? We might be at 400,000 deaths or more. That is an atrocious outcome, just unbelievable. The only thing that I want to add is that is not fated. There is nothing written in stone that says that's where we have to be. And if there is one state that I believe has the intellectual and other and financial and other types of capacity to avoid that future, it is the Commonwealth of Massachusetts. Other states can as well. But one of the things I really do believe is if we can do that, if we can model what a fantastic response to this virus looks like, substantially more testing, a really more aggressive tracing program than we've already installed. And we're doing a very good job. We really are leading the nation on contact tracing. Building in programs for supportive isolation. Planning out how we're going to keep colleges and universities open this fall and showing that it can be done. We can actually not just lead the nation, but we can make the nation then copy us. We've done this for health reform. We've done this for lots of things. This is as big of a health challenge as we face, and I really do think Massachusetts can lead the way. But it's not going to happen magically. It's going to happen if folks on this call decide that we want to be a model. We want to be the South Korea of the United States. We want to be the New Zealand. We want to be the Germany. There are lots of models we can turn to. If we do all of that, I think we can get to a much more effective response, far fewer deaths, a more open economy, and other states following along. So I want to say thank you to the Massachusetts Association of Health Plans for having me on. And I'm not done. I'm just done with my formal remarks. And I'm looking forward to questions and discussion and answer as we wrap up here. So thank you.
Dr. Jha, that was terrific. Thank you so much. So I have so many questions, and I know we have questions from the audience, but I guess a couple of things come to mind. Relative to testing, how many tests do you think are ideal for Massachusetts to do a day? And how exactly do we reopen schools? Because I think that really is the key to restarting the economy.
Yeah, two good questions. Okay, so let's talk about how much testing we need. So I'm going to answer this question for the country, and then I'll come back to Massachusetts. There are right now 3 numbers out there for how much testing the country needs by 3 different groups. And I'm going to tell you the 3 numbers. I'll tell you that we're one of the 3 groups, and then I'll tell you why our number is probably not even the best number, and the best number is probably a different one. So I'll give you the 3 numbers. They are either about 1 million tests a day for the country, 4 to 5 million tests a day for the country, or 30 million tests a day. Let me just give you a little background on all of them. The 1 million tests a day is from us. And we really did it based on looking at what the size of the outbreak is in the country, how many cases there are, and ask the question, what would it take to be able to identify most of those cases, either through symptoms or through contact tracing? And our best estimate is between 900,000 and 1 million tests a day. And for Massachusetts, because our outbreak size was quite large, we thought the number was about 60 to 70,000 tests a day, way above where we are. But that number comes down. And if I were to rerun those models now, that was a little while ago when the numbers were much higher, we would probably be estimating that we need about 35,000 tests a day for Massachusetts, based on our model. You have the Safra Center here at Harvard that has a different approach, also very much focused on testing and tracing. And they come up with 4 to 5 million, but a much more aggressive, more contacts, more aggressive testing. And then last but not least is you have Paul Romer. And Paul is a Nobel laureate. He's at NYU, who has been arguing for 30 million tests a day. And in Paul's vision, you have essentially ubiquitous testing. Every day, everywhere you go, you can have testing everywhere. Under Paul's idea, we would be doing about 600,000 tests a day in Massachusetts. Okay, so 60 times what we're doing now. Obviously, very, very hard to achieve. But my take is there probably is no magic number. And the way to think about it is the more tests you give me, the more freedom you get, the more security you get, the more safety you get. So let me give you an example. Right now, we're doing 9,000 tests a day. If we got much higher than that, we could start doing regular testing of nursing home residents, workers, and even visitors. We should be testing everybody who gets admitted to the hospital every day. Many of the hospitals in Massachusetts are starting to do that. I would like to be able to start testing office workers on an ongoing basis. How often depends on how much testing we have. There are people who've argued for, if once we get to rapid antigen testing where you can get a test back in 15 minutes, could you use that at a restaurant? This was a suggestion from a Dallas Fed Reserve president I was speaking to about 2 weeks ago. He said, what if restaurants, 15 minutes before you show up to the restaurant for your dinner reservation, you get a nasal swab, you get a test. If you're negative, you go in. If you're not negative, you can't eat there. People would feel a lot more comfortable going and sitting inside of a restaurant if they knew that everybody had gotten tested in the last 15 minutes. So you can imagine, actually the other place where people have brought it up is the idea of getting on an airplane. One of the main ways that we have economic activities, people fly, they travel. You're going to feel a lot better getting on an airplane if you know everybody's gotten tested in the previous 24 hours and has tested negative. So there is no magic number. The more tests you have, the more you can do, the more security you can add to the system, the more comfortable you can make people feel about engaging in economic activity, and the more you can drive changes in the economy. So now let's talk about schools in the fall. I think schools in the fall are going to be very, very hard. If for people who might have been following, Israel opened up their schools about 2.5 weeks ago, and there was a piece, I think in NPR this morning, that they're essentially having to shut everything down just a few weeks after opening. And Israel is a small country, very, very technologically sophisticated, quite impressive in how they've managed the disease outbreak, and they had to shut most of the schools down. So this is going to be very hard. The strategies that I have been arguing for, and I think a bunch of people have been working on, is we really have to think about, I had argued, I understand that this is likely not going to happen, but I had argued that why don't we open up our schools in August? I understand you got to probably go to the unions and you have to work out some deals and details, but what if we ran school from August until November? We'd be able to get kids, not like kids are a lot of kids are not going to summer camp anyway this summer, and there are a lot of other school activities that are not happening in the summer. So that would have been a great option to consider and explore with the idea that if you can get, at least you can get August, September, and October in, even if things get bad and you have to go to online in November, you got 3 good months in. I know there's some challenges. Some schools don't have air conditioning. I'm not saying this is perfect, but that was one idea. Second idea is we really probably do have to think about thinning out the classroom. So no large assemblies. Can we think about adding some way of reducing the number of kids in classrooms you have, and then putting in things like dividers and other ways of trying to create a bit more space between kids. These are not my ideas. These are things that South Korea, Germany, other places have been doing. I really do think we need a testing strategy and thinking about how to test kids on an ongoing basis, how to test teachers and staff on an ongoing basis is going to be really important, because what you want to do is you want to catch outbreaks early before they've spread to hundreds of kids. And you may need to shut down schools for short periods of time for cleaning, for testing everybody if you start seeing an outbreak. So there's a whole set of strategies. And the last but not least is we're learning that when you're indoors, the ventilation system of that space can make a very big difference in terms of disease spread. So I don't know, this is obviously not my area of expertise, thinking about ventilation of buildings, but there are other people for whom this is their area of expertise. All of our schools, I assume right now, are getting evaluated and examined and thinking about what kind of filters do we need to put in, what kind of air circulation do we need to have. What are you going to do? Probably should close cafeterias. So if you close cafeterias, how do you get food to kids? Where do you have them eat? There's a whole set of issues that need to be sorted out. And I just don't know how much of that is happening in school districts across the country.
Thank you, Dr. Jha. We've spent some time talking about testing as part of the approach to reopening the state. Wonder if you can speak a little bit about vaccine development. So we know previously it's taken 4 to 5 years to develop vaccines, and that's on the low end. So is a vaccine in 18 months for COVID too optimistic?
It's a great question. I think the answer is I don't think it's too optimistic, but let's dig down a bit more into that. There are lots of people, and you could have many other public health experts speaking to you, who would say, Ashish's assessment is too optimistic. We're not going to get one by that time. Let me tell you why I am optimistic. Well, let me actually lay out first the case for why you should be pessimistic, and then I'll counter it because I think it's more useful. So people do bring up the 4 to 5 years. People bring up the fact that it has taken us 20 years. We still don't have a vaccine for HIV. And that there are, serious issues in developing a vaccine and making sure it's safe, not just effective. I get all of that. I think that's all legitimate. The things that make me optimistic are I do think we have pretty good evidence that we can stimulate immunity against this coronavirus already from the phase 1 data and some early phase 2 data. We came pretty far along in developing a vaccine for the SARS coronavirus, and so we have a lot of experience from there. That's the Oxford group doing what they're doing. And there has never been an effort. This is really unprecedented, the amount of effort going into a vaccine for this virus, for the SARS-CoV-2 virus. And so what you have is 100 plus vaccine candidates, a dozen in clinical trials, and many more coming, and just incredible level of investment. Am I confident that the Moderna vaccine will work? I'm not. I don't know which vaccine will work. I think that given how many different efforts there are going on, that I am pretty confident that 1 or 2 will work. I'm actually most days pretty confident that we might get 5 or 6 different vaccines that will look pretty effective. The issue of safety is going to be very, very important. And that's why we're going to need large clinical trials with tens of thousands of people. There is going to be a temptation this fall, maybe even around the election, to try to rush things and try to get something out that hasn't been properly vetted. I think that's going to be a mistake. I think it's better to take an extra month or 2 and make sure that we have good safety signals on these vaccines before we go give it to millions and millions of kids. And I'm sorry, not just kids, adults too, but kids too. So I think it is possible. We're going to get into phase 3 trials into the late summer, early fall. And my guess is that if everything goes super well, by early 2021, we'll have a vaccine that where we'll have enough data to know whether we can really start using it in people. Operation Warp Speed from the White House has made a decision of essentially pre-ordering or pre-manufacturing 5 different vaccines, depending on how they do in the next couple of months. Based on that, it's possible that by the time we have the data, we have 100 million doses ready to go. In which case, you can imagine that by the springtime, we could start giving out vaccines. At the end of the day, it will depend on how confident people feel about the safety and effectiveness of the vaccine. The last point I'll make is that we may not get the kind of vaccine we're used to with measles, where you get it once or you get a booster once and then you're good to go. It may entirely be possible that this is a vaccine that generates immunity for 12 months, in which case we're going to get an annual vaccine. That's fine with me. I think I'll take that. Anything that really reduces the likelihood that we get serious complications from the virus is going to be key. So I am optimistic, but I appreciate all of the complexities that people are raising about getting a vaccine by next spring.
Thank you. One of the questions we've gotten from attendees, and just a reminder to folks, if you have questions for Dr. Jha, enter them in the Q&A box and I'll read them aloud for him. One of the questions we've gotten goes along with concerns around efficacy of a vaccine. We've been hearing a lot of questions about the efficacy of COVID antibodies. So wondering if you could talk a little bit about antibody testing and if you have any insight into when we'll have better information or clarity on how effective antibodies are and for how long they provide immunity.
Yeah, great question. This is one where the science is moving pretty fast. And so if I was speaking to you a month ago, I would have given a different answer, but let me give you my best answer based on where I think the science is today. And I'll give you both what we know for pretty sure, and then where I think we are likely to end up, but we don't know for sure, just so you know where the evidence is. So today, I would say I'm pretty confident that almost everybody who gets the infection and gets better from the infection generates antibodies. We weren't sure of that a month ago. A month ago, we had some reasons to believe that maybe it's 20 or 30% of people weren't generating antibodies. I think we now think that pretty much everybody generates antibodies and generates antibodies in probably large enough numbers that if those antibodies were protective, that those people would be protected. We don't really understand the mechanism of protection so well. Is it all antibody mediated? What are the role of T cells, other parts of the immune system? So there's a lot that we don't understand, but we're finding that most people are generating antibodies, and that's really good news. Second is I think there is pretty good evidence that those antibodies are protective. So a big part of the question has been, if you have antibodies, are you immune from getting the virus again? And what I would say I feel very confident about is right now, the data seems to suggest that if you recover and have antibodies, they're going to be high enough titers to potentially provide protection. And then when we look at the data, and we don't know this for sure, but my best guess, and it's a guess, but on the data, is that those antibodies almost surely are protective. It doesn't mean you can't maybe get a mild virus again. You might be able to. We haven't seen much of that, but it's theoretically possible. But I don't think that if you got reinfected, that you would get sick. And I'm not at all convinced that you could even get reinfected. So pretty confident that if you've cleared it, you're not going to get sick again. Somewhat confident that if you've gotten it and cleared it, you won't even get infected again. But that second one, I'm a little less sure about. We just don't know. We don't know. We're going to learn a lot more in the upcoming 2-3 months because of two things are going to happen. One is people who've recovered are going to be re-exposed. And if we keep tracking those people over time, we'll be able to tell if any of them are getting reinfected. Second is there are some efforts to do challenge studies where you actually take people who've recovered and expose them purposefully to the virus, obviously voluntarily, otherwise it would be deeply unethical. Actually, there's a lot of question of even voluntarily, could it be ethically done? This is an ongoing debate, but there are some challenge studies that people are trying to create because it'll teach us in much, much faster time period how protective these antibodies are. So a lot more coming. I suspect by the end of the summer, we'll have much clearer picture on how protective these antibodies are.
Dr. Jha, hi, Laura again. So we've had a few questions. The first is, how concerned are you about the protests across the nation and the large gatherings and people, lots of them had masks, but close contact, that we will see huge spikes this summer?
Yeah, so this is a hard one. And let me say a few things about this. First is, I think anytime you see a large gathering of folks, it doesn't matter what's motivating them, you got to worry about those gatherings setting off infections. My general feeling on this has been, first of all, that I very much support the protesters and what they are protesting about. I think that people are, sort of genuinely angry and frustrated and feel like this is a moment to speak up and that needs to be heard. But if you then take the angle of what will it do on COVID, things that make me feel better about the protests in terms of from a COVID angle, they're outside. Most people are wearing masks, and I've been encouraging people to wear masks. And then, the other thing is people try to make estimates of how many people are actually engaging in the protests. And we think somewhere around 1/4 to 0.5% of the population is engaging in protests. So it should not set off massive outbreaks, but it almost surely will increase the number of cases of COVID in the United States. And whether that's worth it or not worth it or wise or unwise is a different set of conversations. But I think we should not overestimate how big a deal this is. It looks really bad because you see those crowds. But when you actually run the numbers and say how many people are engaging in protests, it's probably between 1/4 and 0.5% of the population. So it's not a massive number.
Right. And we've got some additional questions. I'm going to bundle these together. Folks are asking about, similarly, you talked about schools, colleges and universities reopening in the fall. Should employers who have employees who can work from home, should they do that indefinitely to limit the spread? And then folks are asking about home in the summer. Can they have friends over?
Yeah. So let's talk about friends over first, because it's some ways easiest. So certainly if you have outdoor space, if you have a patio, a backyard, having friends over is really, I think, easy to justify. I'm going to assume that you're not in a super high risk population. If you're an older person in your, let's say 70s or 80s, it just becomes higher risk. So you have to sort of factor that in. But if you're not, and if you don't have a severe chronic disease, you don't have immunodeficiency, then I think the idea of getting together with friends in your backyard, maintaining a certain amount of social distancing, all that feels very reasonable and is totally doable. How about inside? Inside is more risky. Would I feel comfortable having 35 people inside my home in Newton this summer? I probably would not. Would I on a Saturday afternoon have 5 people over in my backyard? I'd feel totally comfortable with that. Somewhere in between lies, what are you going to be okay with? 5 people indoors in the afternoon where you can have your windows open feels pretty reasonable to me. 12 people sitting around a dinner table, depending on your dinner table, it starts getting a little bit more risky. It might be okay if we can keep driving the number of cases down in Massachusetts. It'll make me feel better yet. A lot of it is driven by how much a disease is floating around in the community. If there's a lot of disease floating around in the community, all this stuff becomes riskier. If there isn't, then all of this becomes easier. So that's a major component of it as well. But I think it will be hard to have this be a regular summer in terms of the kinds of stuff people do. Okay, colleges and universities. So the university I'm at right now, Harvard, has told schools that they can decide on their own, and a large number of schools have already declared that they're going to be online only. The School of Public Health, where I've been for the last 16 years, has declared they're going to be online only. So a lot of schools and colleges, and universities, I think, are throwing in the towel for the fall and saying it's going to be too hard to pull off, and that we're going to go online. One of the things, I think I said this earlier, but I'll raise again, that I've been raising to colleges and universities, is if you do that, which I understand and it makes sense, I don't think it's unreasonable, you're probably not bringing kids back in January. And it's not clear to me that you can bring kids back at the end of January for a February, March. And so then the question is, are you doing a whole year of online? Bringing kids back in April probably, or May, probably doesn't make sense. It may not be enough time. So that's worth thinking about, is not just what is your fall plan, but what does it say about your spring plan? The university I am going to, Brown in Providence, our university president, Chris Paxson, she has put the stake on the ground that Brown's going to open this fall, and we're going to have face-to-face instruction. And what that has meant is that the universities said, okay, we'll figure out how to make it work. And my guess is that there is a greater than 80, maybe greater than 90% chance that Brown can pull it off. But it's going to take a lot of aggressive work, really aggressive surveillance on testing, probably canceling major varsity sports and other things that bring a lot of kids together, really monitoring how much, large gatherings there are, and then a whole surveillance system throughout the whole semester and year. And then thinking about how you want to manage older faculty, older staff, potentially older students, or other high-risk students in terms of making sure that they have the ability to take time off, et cetera. So you need a comprehensive strategy. This is not a, sure, we'll open in the fall and see how it goes. Because if you try that, you probably won't be able to make it. But I think if colleges and universities are aggressive and really make a plan, they can probably get away with staying open throughout the fall and winter. I don't know if there was a third question in there, Laura, that I did not.
There was about employers. If they have the ability, their workers can work from home, should they just do that indefinitely?
Yeah, I think it really depends on the level of disease burden in the community. Right now, we have still enough cases happening in Massachusetts that, it's not totally straightforward well, let me put it this way. It's always safer to have people work from home. There is a cost to people working from home. And if you can have people work from home, my general inclination is that's great. If the level of disease burden really gets very, very low in Massachusetts, which it is not right now, then it might be pretty easy to bring people back into the office. But I just don't think we're there yet. And that's one of the reasons I have been pushing our policy folks to really try to think about how to suppress the virus, because I think if we can do that, it makes it safer and easier for people to come back into the office.
Terrific, thank you. And I know, Liz, you have some additional questions from the audience.
Thanks, Laura. So one of the questions we've gotten is, why are we seeing higher death rates in Massachusetts and the Northeast versus other states? Is it simply population density, or demographics? Is it the practice approach? What accounts for that?
Yeah, so a couple of things. I don't think that there's anything about differences in care patterns that we are somehow not as good at managing COVID as other places. I don't think that's true at all. Death rates in the middle of an outbreak are very, very, very hard to interpret, because remember, death rate is both the number of deaths over the number of cases, right? And both the numerator and denominator can be off. So if you're really good at a surveillance system that identifies people who are dying of COVID, you're going to have a high number of deaths. And what we know is there are a lot of states where there have been excess mortality, excess deaths, people dying from at home, but never were classified as COVID deaths, maybe because they didn't have good testing. So that numerator can be off. The denominator is also driven a lot by how much testing you're doing. And places that do more testing tend to identify more cases, and that can change your bottom. And then, of course, a lot of this is driven by the demographics. Are you primarily infecting young, healthy people, older, sick people? We've had a lot of older people in Massachusetts, as well as other places that have gotten infected and died. So I think it's a combination of demographics, as well as our surveillance system. And I don't think it's really driven by somehow we have a more lethal form of the virus. I don't think such a thing exists. And I don't think it has anything to do with maybe our care systems are not as good. I don't think that's the case either.
So in line with that, we've seen the virus, disproportionately impacting nursing facility care and day health programs. Wondering if you can talk a bit about what you think the approach should be to nursing facility care moving forward and opening up day health programs.
Yeah, this has been a travesty, to be perfectly honest. 26,000 Americans have died in nursing homes, nursing home residents over the last 2 months. It's really kind of shocking. And it was all completely preventable. I was going back recently and looking at even some social media posts that I and other colleagues did back in early March about how we need to protect our nursing homes. And here we are in early June, and mostly as a country, we didn't do any of the things that were obvious that we needed to do. So now, given where we are, how do we move forward? Obviously, nursing homes can't stay on lockdown for the next 15 months. And so what many of us have been recommending is you need a really aggressive surveillance system for nursing homes, for daycare programs, for any place that has high-risk individuals there. And so surveillance programs basically are about testing. There's a lot of debate on how much testing should there be. Should it be every week, every other week? Who should be getting tested? All stuff that needs to be sorted out. But certainly nursing home residents, workers need to be tested on an ongoing basis. We need some policies around protecting workers. So if a worker doesn't feel well, we don't want them working. We certainly, a lot of nursing home workers work across multiple facilities. That's a potential disaster if any of them get sick. They can infect multiple places at once. So there are a lot of factors that go into how we protect nursing homes, but certainly testing, surveillance, and better policies to protect these places are, I think, at the top of the list.
Great. Dr. Jha, we have a question about the virus mutating and if it mutates similar to the flu. And I think there was a story last night I saw on the news about maybe there was a mutation and it was a less severe strain.
Yeah, so every virus mutates pretty much all the time. Viruses mutate. The question is it a clinically, functionally significant mutation? So that's one question. And that's why people bring up different strains and what does it mean to have a different strain? Second question that comes up a lot is what if the mutation happens so that it becomes more lethal or that the vaccine we develop no longer works? So let's talk about a whole set. I'm not a virologist, but there are virologists who think about these things, and I read them and I read their stuff very carefully and try to sort out what I think is legitimate and good scientific consensus and what is not. And the broad scientific consensus, I haven't seen this thing from last night, but the broad scientific consensus right now, if I ask most virologists, how many different strains of this virus are there? Most virologists tell me the answer is one. There's a single strain. Lots of mutations, one strain. Because they think that functionally there aren't large differences. Now, again, I'm not specifically commenting on that report from last time, just because I haven't seen it. So we're going to act like I was giving this talk yesterday, but what I have said. Second, is that there is a history of when mutations occur, significant mutations. There is a history, there are counterexamples, but the history is that mutations tend to lead to less severe strains. Now, there is some evidence that in the 1918 influenza pandemic, what we call the Spanish flu, that the mutations that happened actually led to more severe strains, which is what caused greater fatality in round 2. That's possible to happen here, but I think that's really unlikely. Plus, the coronavirus is not the influenza virus. These are very different viruses. Influenza mutates all the time. The coronavirus does not, or not in the same way, not functionally significantly the same way. So I'm not super worried about mutations and strains, and I don't think that we are likely to see a mutation that will lead to the disease becoming much more virulent or becoming no longer susceptible to a vaccine that we develop. Am I 100% sure? I'm not 100% sure. It could happen. But most of the experts that I am talking to who study kind of viral immunology and viral evolution are not worried about this either. And so I think this is probably not going to end up being a major issue.
Right. And so now another question from our audience, and something we spent some time yesterday with our board speaking about. The virus has disproportionately impacted communities of color as we prepare to reopen the state and the nation and prepare for a possible second wave. How can we ensure that we better prepare to serve these populations?
Yeah. If there are travesties, this is another one of them, beyond just what happened in the nursing homes. In retrospect, we should have all seen this coming, and we didn't. And we didn't for a variety of reasons. One of them was that we didn't have a good data collection system. One of the many ways in which the CDC has really been ineffective in this outbreak is the entire data infrastructure apparatus for tracking this disease. So what we know is there is some data that testing capacity in neighborhoods with large proportion of minority populations, people of color, Those places have far less testing capacity. It's not where people are putting up testing sites. So one of the things that we can do in Massachusetts is not do that, right? In Massachusetts, we can actually make sure that communities with large proportion of minority people populations actually have very robust testing capacity, because that's one part of it. Second reason we saw these large disparities is who gets classified as essential worker and who has to go in and who doesn't. We need policies to make sure that people are not having to choose between their livelihoods and their lives. So there's some policy issues that we can do there. And then the third, and is certainly a whole lot of work around making sure that the care delivery that happens for people is much more equitable than it has been. And so there's I think, a multi-pronged strategy. But to me, the strategy begins with data. The strategy begins with tracking the data, understanding the real underlying causes that the data can teach us about, and then addressing those underlying causes. There's a whole set of structural issues that we're not going to be able to solve during the time frame of this pandemic. But once we emerge from the pandemic, we have to actually answer a whole lot of broader questions about why is it, for instance, that the neighborhoods where Blacks and Latinos live, for instance, to be much more polluted. We think air pollution is a real risk factor for bad outcomes of this disease. We have to ask about how mass transit works, and are we dealing with that in the right way? So there's a whole set of issues that we're going to have to sort out, but probably can't in the next 3 to 6 months, but absolutely will need to as the pandemic comes to a close.
Terrific. And we're going to wrap up, I think, this hour, and I'm going to give you the final question. That's my question. Since I was having night terrors about a month ago with bad dreams, what's keeping you up at night?
I think the thing that keeps me up at night. So I'll tell you what I used to worry about. I used to worry a lot about what if we can't develop a vaccine? What if antibodies are not protective? They're actually related questions, by the way. I'm just much less worried about that now. The thing that keeps me up at night is a sense that we are just getting used to 1,000 Americans dying every day and feeling like it's no longer motivating policy people. The White House briefings have stopped. The task force doesn't really meet with the president anymore. And we are getting essentially numb to what I think is an astronomical level of disease burden and suffering and death. And I don't see any ending in sight. And to me, if this was fated, if we could not do anything about it, it would be awful, but I could live with it. But instead, what I see is a sense of, well, this is our fate. This is what we're going to have to live with. No other country is living with this. No other country, certainly no other high-income country is going to suffer the kind of losses that we are suffering. And my nightmare is that we just don't care enough to do something about it. And that really bothers me. And I think we can. And I don't think it would take a Herculean effort, but it would take persistent effort from all of us to push our political leaders to be much more accountable on this issue.
Absolutely. And I think it has been politicized clearly at the national level. And that's unfortunate. I want to thank you so much for your time. We have such treasures in Massachusetts, and you're certainly one of them. And we may call upon you in a few months to come back and talk to us and update us. Thank you for your time today. I want to thank the audience for participating, and we'll look forward to our next policy forum. Have a great day, and everyone stay healthy.
Bye-bye.
Bye-bye.